All right, so up next, we're proud to present Patient Power Insights from the Front Lines of Myeloma. This session is made possible thanks to our platinum sponsor, Bristol Myers Squibb, also known as BMS. Now let's begin. Up next, we have Ms. Mariana Broussard. She is the Associate Director of Global Patient Advocacy for Multiple Myeloma at BMS. Her work centers on health equity, cultural programming, and building strong community partners. Please welcome Ms. Mariana Broussard. Joining her is Dr. Brian Engelhardt, MD, MSCI, and a multiple myeloma medical engagement lead at BSM. He brings clinical trial experience and a background in oncology and transplant research with a focus on improving care strategies. So please welcome Dr. Brian Engelhardt. And rounding out our panel is Robert Pugh, a passionate patient advocate and a long-term multiple myeloma survivor who has been a powerful voice in the oncology space. After ongoing chemotherapy and a stem cell transplant, he continues therapy and has been a key contributor to the BMS Patient Ambassador Program. So please give it up for Mr. Robert Pugh.
Thank you so much for the wonderful introductions and for inviting us to be here today. Before we get started, I'm curious, how many people here have heard of multiple myeloma before? Okay, I love it. Love to see that. So today we're here to level set. We want to understand what is multiple myeloma, who does it affect, and how can we strengthen our community's understanding and response. Switch this slide for you. So multiple myeloma is the second most common blood cancer in the United States, with approximately 35,000 new cases diagnosed each year. And African American patients are twice as likely to be diagnosed with multiple myeloma compared to white patients. We also often experience worse outcomes due to delays in diagnosis and treatment. Mortality is also about twice as high in the African American community. I'm so glad that you all are joining us today. Really thrilled to have the opportunity to empower patients today and families with knowledge and support. So I'm joined today by special guests who bring both medical and patient perspectives. We're going to be covering multiple myeloma in the body, how it progresses, how it's diagnosed, and the different types of treatments, as well as discuss potential new therapies, such as CELMoD agents that are currently in clinical trials. So our focus is going to be on learning from each other. This conversation is going to give insight into the journeys of multiple myeloma diagnosis and treatment. So Brian, I'm going to hand it over to you to give us a little more in-depth introduction into multiple myeloma.
Absolutely. So like Mariana, I first want to thank Black Health Matters for allowing us to be here today to talk with y'all about multiple myeloma, the treatment options and new therapies coming out like CELMoDs. It's a very big privilege to be here. And so I am a hematologist oncologist, currently the multiple myeloma medical engagement lead at BMS. I've been with BMS for about 3 years. And before that, I spent about 20 years at Vanderbilt University Medical Center in Nashville, treating various types of hematological cancers, including multiple myeloma. On a personal note, I also want to say it's great to be in North Carolina. I have a strong connection here. My wife and her family are all from Gastonia, so just up the road from here. And then I spent 3 years living in North Carolina while doing my residency at UNC Chapel Hill. So definitely a strong connection here, and very nice to be here in North Carolina again. So what is multiple myeloma? So myeloma is a blood cancer, and specifically it's a cancer of plasma cells. But before we get into the cancer of plasma cell, what is a plasma cell? And that's a specific white blood cell that normally helps your body fight infections. And when these plasma cells become cancerous, they grow uncontrolled like other cancers. And what they do is they push normal, healthy bone marrow out of the way. And basically, patients can become anemic or have low blood counts. The multiple myeloma can also destroy, or what I call eat away at bone, and cause lytic lesions and cause bony pain. They can also secrete abnormal proteins that can injure kidneys and other tissues. And also, because it's a defect in your immune system, patients with multiple myeloma can be at risk for recurrent infections. So the key thing is multiple myeloma is a hematologic cancer. So it's disseminated, it is spread throughout your blood and bone marrow at diagnosis, which is unlike solid tumors, which generally begin as a lump or a bump in a solid organ like breast or lung. So there is some differences there. And then another confusing point is that multiple myeloma is not melanoma, and melanoma is not multiple myeloma. Melanoma is specifically a type of very potentially aggressive type of skin cancer. So multiple myeloma and melanoma are two different types of cancers. So that's very important. For patients who are diagnosed with multiple myeloma, it's also important to know that their usual treatment course is dictated by a multidisciplinary team, meaning it's groups of different doctors, nurses, clinicians involved in their care. And that could be hematologists, oncologists, it can be radiation doctors, radiologists, pathologists, supportive care. So it really takes a team and a village to help treat and care for patients with multiple myeloma.
Perfect. Thank you so much. Robert, can you share with us what were the symptoms or circumstances that led you to seek medical attention when you were diagnosed?
Good morning. My name is Robert Pugh. I live here in Charlotte. Although I'm not from Charlotte, I've been here about 10 years or so. And I've done quite a bit of work in the medical arena. And so there was a sensitivity that I had. I run long distance and middle distance, so I'm very sensitive to different aspects of my body. I was preparing for a race, 15K, and I went in simply for an examination. I was experiencing minor pain, but as a runner, you're accustomed to pain. And that pain was in my back. And so when I went to my doctor for the physical, he recognized that my white blood cells had decreased. They were not below the average number, but for me, they were below what he was accustomed to. And he asked that I would take further tests. And after doing further tests, they recognized, he gave me a card. He said, I need you to go see this guy. And I looked at the card and all my antennas went up. Why am I going to see this guy? And it was going to see an oncologist. And at that point, he said that I had multiple myeloma. And that was French to me. I had no idea what that was. I do not and did not ever have a history of illnesses of any kind. I run away problems. I go out on the track and the problem won't be there when I'm finished. And so it just kind of threw me that he would say that I had myeloma, and I had no information whatsoever as to what that was. That began the journey.
Okay.
That began the journey. It was a shocker. I'll give you more information as we go.
Thank you.
You're
Yeah. Brian, can you give us an overview of how multiple myeloma is typically diagnosed and if there are social or economic factors that influence diagnosis and treatment decisions?
Yeah, well, I'll first start with like some of the symptoms. And so, like Robert said, his course was kind of very typical for many patients with multiple myeloma, and that patients can often present with pain, and it's in the back, it can be in the hip or ribs. The other thing is we all, especially as we get older, we all experience pain, but I think there are some symptoms that are more worrisome than others, like pain that wakes you up at night, or pain that doesn't go away after a week or two of rest, or pain that you can't attribute to some strenuous activity or something that you've done in the preceding couple of days. So that is one of the characteristic symptoms. Patients can also have fatigue from anemia, recurrent infections, also fairly common too. So multiple myeloma is a very tricky disease, and I'll say that there is no one test generally used for diagnosis, and it's really a series of tests. And blood tests can be used to look for abnormal proteins. These abnormal proteins can also be found in your urine, so sometimes physicians will ask for a urine specimen or to collect a urine over 24 hours. Because myeloma can damage bones, radiology often plays an important part. So x-rays, CT scans, PET scans, MRIs can all be performed. And then, of course, a bone marrow biopsy where a needle is placed in your back of your hip and pelvis, and a small piece of bone marrow is taken out, and abnormal plasma cells are seen. But I've told you, myeloma is very tricky. So you can have abnormal proteins in your blood, but not in your urine. Or you could have an abnormal x-ray and not have any abnormal proteins. So really, you kind of have to go through all these tests to help make the diagnosis, and it can change over time. So some patients with myeloma are asymptomatic. They have no symptoms whatsoever and are diagnosed incidentally. So you go for a routine checkup and your doctor finds out that you're more anemic or your kidneys aren't functioning normally. Sometimes that can lead to a diagnosis of myeloma. Also, as you might expect to, multiple myeloma diagnosis is often delayed. And that's because the symptoms can be subtle or attributed to many things. Because I think we can all admit that we probably all have had back pain at some point. But if the pain persists, it needs to be checked out. And after a while, myeloma could be diagnosed through that manner. So economic and social characteristics can play a large role in the diagnosis, treatment, and management of multiple myeloma. For example, access to healthcare. So if healthcare access is limited, symptoms may go undiagnosed or untreated. Insurance. Let's be honest with each other. Healthcare in the United States is expensive. Large out-of-pocket expenses or insurance may dictate which tests are done or which treatment are available for you. Health literacy and language. So some people may have difficulty understanding their diagnosis or what their treatment options are. And then what if English isn't your first language and all the information that you're given to and the physician that you're speaking with is speaking to you in English? So that certainly is a barrier out there. But there are support networks out there that can help with emotional, caregiver, financial support. And it's really important for patient advocacy groups such as Black Health Matters to help educate and spread awareness about different types of cancers, including multiple myeloma, the symptoms associated with it, and also identifying barriers to care and breaking down those barriers.
Robert, can you describe for us your feelings at diagnosis, even if you could put it into a few words, and then would love to hear a little bit more about your initial treatment journey. What were some of the things that you went through?
Initially, when I was diagnosed, I thought they had the wrong person. They had somebody else's information. That can't be mine. And it was quite surprising, shocking. Okay, where'd this come from, and what do we do with this next? My initial response was just I wasn't there. I didn't have the intellect to apply to my psychology, and I mean it. And so when I received my initial diagnosis, I took it. I listened to it, and I walked with it for about 3 weeks before I would say anything to anyone. I wanted to digest, what do I do with this? What's next? You gonna believe God for this? or you're going to go through the procedure, or you're going to have a little bit of both. What do you do? Everything that's inside of you rises to the top, and you've got to take steps. And so that was a journey. That was a real interesting journey. I wrote a paper once that said I learned to cry, and because you learn that things open up, and it was so liberating. Um, the initial journey of the treatment was then offered 3 parts. The induction phase, which was we're going to start with the medication, with the chemotherapy, and it was a 3-part chemo plan. And my daughter told me that I looked worse than I did before they started, because now I'm taking some very, very strong chemicals that my body was not accustomed to. I'm psychologically trying to believe that chemicals are going to be magic and it's going to just go away. So as I took the chemicals, I started to lose weight. My energy level began to drop. And you just have to go through it. Psychologically, I'll talk to you. I was a mover and a shaker. I wasn't moving or shaking. So I found myself avoiding people, because you're just not who you thought you were. And so now we're going to have to change who you are during this time period. And what's the best way for you to do that? And the best way for me to do it was to do it alone. And that was my journey. So we started with the induction phase, those 3 chemicals, and that went about 4 months. The objective is to eliminate the active cancer in your body. After that, then we prepared for the stem cell transplant. Stem cell transplant sounded very scary to me. I'm using terms that didn't really apply, like crying and scary, and that wasn't part of who I was, but it's a part of what I became during that time period. Because transplant, I thought they were going to cut me and move something from here to over there. I just had no frame of reference for that. I used to work with cardiac surgery, and I understood what it meant to cut and to move, but not this. And so, preparing for the stem cell transplant, I will say this. Let me interject this. I had a tremendous trust and relationship with the nurses there. I was there at Levine because 80% of what I learned, they taught me. They know and they work with this. Now, I was only the 3rd transplant done at Levine. Levine, we were just building. I say we because I got involved at that level. They were just building the myeloma program. And so I was treated extremely well. I went in as an exceptional patient. Exceptional because I was in very good shape. I lived pretty good. I drank a lot of water. So it wasn't as if we've got to take care of these maladies before we can work on this. And it's important that you try to keep yourself in as healthy as you can. And it doesn't have to be transport your entire life, but put this away, put that away. You've had your time. You've done 20 years with that. Leave it alone now. And so, and so it'll benefit because we don't know what's coming up the road, and it'll all work out better if you're healthy, if you're as healthy as you can be at this particular time. So we went through the stem cell transplant, and it went well. It went very well. I'll move on. There's a part of there's a part of the stem cell transplant where it's recommended that you don't have a lot of people around you because now you have no white blood cells. You're like a baby. You have nothing to fight bacteria with in your body. And if you got a lot of visitors coming in, you're exposing yourself to situations that's unnecessary. And so I asked for, my sister was going to visit, I asked them not to visit for about 3 or 4 days. So that left me in there by myself, but with the staff. And I would really communicate because I have a high degree of respect for the staff. And sometimes, you got to raise that. You may know them, but they know what they're doing. They see this every day. And and I got so much information from them. And so after the stem cell transplant in the hospital, about 13, 14 days, you're released and you feel like a new person. Cancer's out of your body, the sun is coming out and sky is opening, you're breathing better, everything's feeling real good. And then you go into the doctor and he says, we're going to start a maintenance program. I said, maintenance for what? You are, we're done, aren't we? Yeah, I'm feeling no pain. I'm feeling good. And that's when the reality comes in that myeloma is not something that comes, you take care of it, and it's over. It's almost guaranteed that it's coming back. Now, when the maintenance is designed to offset it so it doesn't return quickly. And again, myeloma is not fair. I've learned so much from other patients that's gone through this, and they've had a stem cell, and within 3 months, the cancer had returned. I went 7.5 years before that. And so in between that 3 months and 7 years, there's so many different people that have different experiences. And the back something may happen here, and the kidneys, as the doctor mentioned. And it's just not a one-shop situation. It can change. So, you say, oh, I thought I was finished. I didn't want to take any more medication. Okay, but let's look at it. And so I went to the maintenance program, and again, I went 7 years. So it went well. You're welcome. Go ahead.
And then so glad that it has been that long. Brian, I definitely would like to have you help us understand what a newly diagnosed patient may go through today. Thank you so much for explaining stem cell transplants well. I think we got that very well. But I am curious if you could also highlight some of the innovations in treatment that are coming, maybe new therapies and clinical trials.
Yeah, I'd be happy to. So first off, before getting into all the nitty gritty, I want to say that this is, a really exciting time. There's a lot of new treatments and options out there, and people are living longer with myeloma than they ever have before. The other thing that I'm going to point out is some kind of generalities of treatment. But I want to say, as you've kind of heard from Robert, that multiple myeloma is a very heterogeneous malignancy, and each patient's journey is different and unique. So take what I'm saying with a bit of grain of salt. But in general, there's several phases to treatment of multiple myeloma. There's an induction phase, and this is the main goal here is to reduce the amount of cancerous myeloma cells, the plasma cells, and that's to decrease symptoms, reduce complications, and improve survival. It generally involves what we call a cocktail of medications, as you may have heard. The medications usually include an IMiD, like lenalidomide, a proteasome inhibitor, steroids, or monoclonal antibodies. After induction, patients are often recommended to have a stem cell transplant, an autologous stem cell transplant, if they are eligible. I want to clarify that, as Robert said, this is not a bone marrow transplant from someone else. You're not getting someone else's bone marrow or organ. Your stem cells are harvested. You receive high doses of chemotherapy, and then you're given your own bone marrow and stem cells back, basically to replenish so that you have normal, healthy marrow. It's very intensive therapy. It's important to know that this type of treatment is usually done at specialized centers, like at academic or university facilities or tertiary care centers, and often requires time away from work or home to have these types of therapies done. Following that, maintenance therapy is often offered, and this is a lower dose of therapy that helps to suppress the myeloma, keep it away longer, and hopefully allow the patient to have a great quality of life during this time. These therapies work, and they work well for the vast majority of patients. Many patients go into remission, and it can last for years, but almost all patients will have relapse at some point. So we need new therapies, better therapies, both up front and during relapse. And so there's a number of new therapies that you may have heard about. One is is CAR T, which is very exciting. And that's when the patient's own immune system is taking their own T cells, and those T cells are taught or engineered to actually fight the cancer, and then they're given back to the patient. There's also a treatment called bispecific antibodies, and these medications are given to the patient, and basically they connect the patient's immune system or immune cells to the cancer to allow it to kill it. And then there's a medication called CELMods, which is represented by iberdomide and mezigdomide. And these are very interesting novel compounds that are oral and meet the patient where they're at. And they basically build on the legacy of older medications, these IMiDs, and they're more potent, and they're being studied to see if, and what we believe them to be, is more efficacious and more tolerable than these other medications. And I can kind of briefly describe their mechanism of action, and kind of two ways to think about them. Some people call them like a cleanup crew, or another aspect is a kind of like a PEP squad for your immune system. And so these medications, the CELMods, iberdomide and mezigdomide, they target abnormal proteins that the myeloma needs to survive, and targets them for degradation, like you throw away food into the garbage or into a garbage disposal. And when these crucial proteins are degraded, it causes the myeloma cells to die off. But interestingly, when these abnormal proteins are reduced, it actually helps to stimulate or activate your immune system, which then allows your immune system to attack the myeloma in a different manner, which is we're very hopeful and interested in these compounds. It's important to note that as we believe it right now, multiple myeloma is a treatable but not yet curable disease. And we think that these immune therapies and CELMods are really going to give hope and improve outcomes and survival for our patients with multiple myeloma in the future.
Thank you.
Thank you, Beth.
And then, Robert, just if you could quickly share maybe an inspiring story and just speak to the importance of staying informed about multiple myeloma, or any advice you would give to a newly diagnosed patient who's feeling overwhelmed, and then hopefully we'll have time for a question or two.
New patients, I was part of the orientation team there at Levine for about 3 or 4 years, and so a lot of what I've learned and I share, it's the stories of many myeloma patients, and we used to have a lot of written material, a lot of pamphlets, a lot of books that were available. I've got a library, and it gives you an opportunity to study. Now everything's online, and you really have to filter it and understand the organizations that you're accessing. In one of the in one of the meetings that I was a part of, tremendous people. It's not a certain type of person that comes up with myeloma. I mean, just tremendous people, salt of the earth people. And I was in a meeting, and there was a young lady and her husband. Every time you see them, you smile, because they just had that aura, and they would come in to the meeting, and I usually, believe it or not, I just sat in the back and never said anything, because I want to learn from what they're experiencing. One Sunday, well, not Sunday, it was Saturday meetings. One Saturday, she and her husband, they said, "Robert, I'd like to meet with you next week. We want to talk about a few things." And I said, "Okay, we can do that." And as I scheduled to meet with them that next week, I went to her funeral. Myeloma is not something that you can dictate how it's going to perform, how it's going to operate. I've walked with a lot of people, and I've seen a lot of them that are not here, and just strong, good people. And you look for, did they do anything wrong? Is it something that they could have done differently? And the answers are not there for that. And again, that was just she and her husband, and I can tell you stories of it, and it's a privilege it is a privilege when I get a chance to stand in front of patients and share information, just a little bit that will help them navigate this situation, because there's some real basic information that has to be done. Things as simple as drinking water. You put that much chemical in your body, it needs to come out. It's got to get out of there, and you've got to drink. And that's what they told us during stem cell transplant, that we're going to give you all of this, but you've got to drink enough water, and we're going to come in and measure all the water that comes out of you, because it's that serious. And so there are situations where people have done extremely well. I've seen guys come through on a wheelchair one week, and he's up walking around the next week. And so there's a lot of hope. There's a lot of opportunity. There's a lot of new things that are occurring. I've had a chance to go to the labs up at Bristol Myers and talk with a lot of the scientists and the chemists, and it's encouraging. But we have so much as a patient, as a person. You have to take ownership for what you're being told, and you have to walk out your part of this particular disease. Yes.